Good morning, ladies and gentlemen. It is now 10 o'clock on Monday, the 20th of March 2023, and this is the Health and Care Overview and Scrutiny Committee. It is the last committee scheduled for this municipal year, so let me start off by saying thank you to you as committee for your attendance, equally for the insight and the work that you bring, and at the same stage to thank the officers and our guests for the way that scrutiny has been undertaken over the last year. I would also like to pass on my thanks and congratulations to... It's not often I can hear myself talking again, but I'd also like to pass on my thanks and congratulations to Deb Breeden on her confirmation as the Overview and Scrutiny Manager. And at the same stage, I would also like to congratulate Zach Simister, next door to me, who has been appointed as the Scrutiny Officer. Thank you. So, welcome to councillors and to our guests. I would like to extend a special welcome to our new committee member, just at the end of term, but to our new committee member, County Councillor Mike Sutherland. And let's move on to the agenda this morning. I am your chair, County Councillor Jeremy Pert. The only introductory remarks I would like just to make before we start is I think members have seen the response from Amanda Pritchard's office regarding integrated care hubs. I suggest at this moment in time we note that and hold that in reserve pending a business plan that then is supported into NHS England. Are we in favour of that course of action? Yes, Chair. Thank you. I think that was unanimous, so that is good news. And I think that we will also come later on in the agenda to... what else are we going to come to? We will come to one of the other elements that we've had responses on a bit later in the agenda. So, can I remind committee that today's meeting is being recorded, and for those who want to watch today's session back, they can find the recording on the County Council website. The meeting is being beamed live for people to be involved and will cut off 20 seconds after the equipment has stopped. All voting members are in person, and there is a variety of people both in person as well as virtual guests as well. I would ask our guests, as usual, to accept that members have read and digested the papers provided, and as a result restrict their comments to 5 or 10 minutes depending on the item. And I would ask committee to focus on the tangible outcomes for our residents of Staffordshire. So on that basis, let's move to the agenda proper. So first of all, apologies.
Good morning, Chairman. I've received apologies from Councillor Jill Hood, Councillor Lynn Hingley, Councillor Keith Flunder and Councillor Barbara Hughes.
Can I just confirm that we are quorate?
Yes, Chair.
Thank you, that's helpful. Item number 2, declarations of interest. Do we have any declarations of interest for this morning's agenda, please? County Councillor Anne Edgeler.
Thank you, Chairman, and good morning, everyone. Yes, I'm Partner Governor on the Midland Partnership Foundation Trust from the County Council. Thank you.
Thank you. Noted. County Councillor Bernard Peters.
Thank you, Chair. I'm the Staffordshire Local Authority appointed Governor at UHDB.
You are indeed. Thank you. Any other declarations of interest for this morning's agenda? Thank you. Let's move on to item number 3. So we would like to approve the minutes from Monday the 13th of February 2023. Can I just ask that we correct the 2 lots of help, which is midway down page 2, please. It says to help. We only obviously want to help once and get it right first time. With the exception of that, can we approve the minutes as... Sorry, Mike.
Thank you, Chairman. It's not showing that Councillor Norman attended in my presence, showing on the attendance list.
Oh, I can remember that, yes. If we can make that amendment as well. Are we in favour for those people who are in the chamber for approving the minutes? Okay, that's good, thank you. I'm also reliably informed that all actions have been followed up and the information circulated. Just one aside, please. I would like for next year, i.e. from May, to bring in a system of numbering the actions alongside the actual actions that we agree, and that we'll create an action log that we just circulate alongside the minutes so that we can make sure that we do follow up all the actions and they're completed. I note, for example, in the last minutes there were 4 sets of actions. It's very difficult to track through over months, but we do need to make sure that they are delivered. Are we in favour of doing that? Thank you. That is good news. Thank you. So let's move on to item number 4, which is entitled Social Care Workforce Update. I think we are with you, with a Cabinet Member, Julia Jessel.
You had to think about who I was, wasn't you, this morning?
Well, I was wondering whether I shouldn't have introduced Amy first, but, but then it became too late.
I'll believe you, Chairman. Thank you very much. And thank you very much, everybody. There's been a significant piece of work done in terms of the social care workforce strategy. As we all know, it's across the national headlines, recruitment and retention in social care workforce has its challenges, as indeed it does in the NHS and in many other industries. There are a growing number of vacancies and it is becoming increasingly difficult to fill those. So we're in a very competitive market. And in addition to this piece of work, the leader of the council has led another piece of work with our HR department to make sure our recruitment processes, right from our front door through the whole recruitment process, is going to be far quicker, far slicker, not reducing our standards, but where you're in a competitive marketplace, you haven't got the luxury of spending weeks going through your recruitment process. So underlying that is the fact that we recognise we need to improve that process, and that work's been done in addition to this. This report, in effect, sets out what we've done in terms of this strategy document. I know I mentioned it at full council last Thursday, and there were a few blank faces, so I have asked Amy if she can make sure that every member gets a copy of this. This strategy is not going to be delivered overnight. There is a significant number of work streams, I think there's 8 work streams altogether, that will start to move this agenda forward. It's not just about recruitment, it is about retention. And it's based on significant amount of work talking to providers, to staff, to a range of organisations, our partners such as the NHS, to bring together what are the key issues that people working in the care industry, as I call it, what issues they have. And as I said last Thursday in full council, I don't, overlook the fact that money is a key element, but actually what I found really heartening is how people enjoy working in the caring industry and the personal satisfaction they get. So we have got some really strong foundations to work from, and that is what this strategy sets out to do in terms of recruitment, training for those who want to make sure there is a proper career progression. Also, making it easier for people who are thinking of coming into this industry to know where to go, to get information so that they can make that first step to approaching whether it's a private provider or ourselves as a county council. And I think that's the one thing that is a real strength in this document. It's not about our recruitment and retention. It's about recruitment and retention within the whole industry. It's helping providers who find certain elements, whether it's, the paperwork associated with somebody who wants to come from abroad to work with us. It's actually working together as an industry to make it more attractive, more effective for people to join. And I think that's one of the strengths of this document. In terms of any other reference, I'm more than happy to answer questions, but I will now hand over to Amy Duffy, who has a far more in-depth knowledge of this. But Amy, over to you.
Thank you. Taking the paper as read, I won't seek to repeat the entirety of the paper. I thought it might just be useful to give you an oversight of the size of the workforce that we are currently referring to. So within Staffordshire, we have 21,000 roles. That covers both from our social workers and our occupational therapists through to those individuals that would be working in care homes, home care settings, day opportunities and personal assistance. As anticipated, you may recall that we came and presented to yourselves back in October. We have had some revised figures from there since that time, and what that does demonstrate is that we do have a downturn in the workforce, which was anticipated with the economy reopening post-COVID-19. So just to give you an overview, we have approximately 11,500 employees working in residential and nursing care settings. We have 7,200 providing home care, which is probably our largest reduction. We're reporting approximately 700 less staff than we talked to yourself in October. And we've got 950 working in community-based care opportunities, so that's predominantly our day opportunities. In addition, we have approximately 1,400 personal assistants, which will provide support to both children's and adults, and they will be working across both social care and the NHS. So that just gives you an overview of the size of the current workforce. The next key statistic that I would bring your attention to is that if we utilise the data that is offered by Skills for Care, which is a national data source which provides the overview of the size of our workforce, and we actually look at the projected needs of our local population, by 2024 it is projected that we're going to need a workforce of just under 24,000. So if we take into account turnover and the increase in demand, that is, we are looking at needing a further 6,300 staff to meet our local needs within 2024. So the challenge for us is real. The strategy sets out a series of 8 key work streams and actions. We anticipate the strategy that will cover 5 years in the first instance, and the actions contained within are a combination of short, medium and long-term actions. From this, in consultation with yourselves, we would propose to provide yourselves an update in approximately 12 months' time to give you an overview. Just noting, I'd be happy to answer any questions or provide any updates in the interim, as that would be required. In terms of our marketplace, we do have providers that are really keen to work with us. As the strategy demonstrates, we've pulled this together with a number of partners, including representatives from the Staffordshire, our Staffordshire Care Providers Forum. In addition to meeting with ourselves and being very practical and very hands-on, they do have an appetite and a desire to meet with yourselves as members and as representatives of this panel. So I would be happy to take away an action to establish that conversation with interested parties so you can understand their direct perspective and we can further work on different ways of working together to implement the strategy and achieve our aims. Thank you.
Thank you, Amy, and apologies for not introducing you at the same stage as a Cabinet member. Phil Hewitt.
Thank you. Mr. Chairman, my question has a little bit of a lead up to it, so you'll have to excuse me for that. Within a scrutiny committee, the danger is you will always use a personal experience rather than a wider breadth, and it's difficult not to do that. So I have a family member who worked in care for a number of years. So I have sort of a real insight as to how that works. I also had a mother-in-law from my late wife who was in care for a number of years and had quite a lot of different experiences. So it is so easy, as you're talking, to pick up the poor experiences, because that's so easy to do. So I can think of a number of items where you think, oh, actually, that didn't work as far as retention as for my family member was concerned, and it certainly didn't work well for my mother-in-law who was in care. So it's so easy to do that. So to put a balance on that, your mindset has to move that the majority of people who worked with my mother-in-law, and she was quite poorly at the end, were fabulous. So you have to put a balance on. There are some wonderful people working in this sector. And there's no doubt there's also a lot of mistakes made. So where am I on this? And my biggest concern is when I look at retention, and retention is a massive issue. And I can understand, because it's unsociable hours, the money's averaged poor. Often, from my experience, they're not particularly treated well. There's a level of lack of appreciation at times. Not all times. I want to put a balance on that, but there is. So what it says in that report, that we're having working groups to talk to various people. So my question would be, are we talking a lot to the people we don't retain? So are we looking extensively at exit interviews to say, actually, why have you left? Are we getting a clear, have we looked at clear patterns? Now, we may have done this, so excuse me if this question, and I hope you do have an answer, but so are we looking at this, and then are we putting policies in place that correct that? Now, you won't solve an individual problem. The person who left with me was because she didn't have any children, and she worked 4 or 5 Christmas days on the bounce, simply because the care agency she worked for said, oh, well, you don't have any children, like she doesn't have the rest of her family. If she'd have had every other one off, she'd have been okay. So you can't solve that, but that's just an overall management thing that doesn't think beyond the immediate. But retention is everything, and that's something we're breathtakingly unsuccessful. Well, the industry is unsuccessful at. So are we looking at that, and we're putting things in place to make sure that we do retain people? I'm done, Mr. Chairman. Excuse me for that being a very long question, but I wanted it balanced.
If I could pick up on the first 2 issues, which is pay and the status of the industry, shall I put it that way, and then Amy will pick up on exit interviews. In terms of pay, I'm the first to admit we all work for money to pay the bills. I can't disclose, I don't think at this stage, what the rate increase will be, because I'm not sure all providers have actually been notified. But we are doing everything we can to increase the rates as much as possible within the budgets, and of course central government has given us additional funds. So the pay uplift will be fairly significant, but I can't divulge it yet. It would be unfair on providers. In terms of status, it's something I'm very, very keen on. And one of the issues that's come back to me is, of course, the nation applauded the NHS, clapping saucepans outside front doors every Thursday, but nobody did it for social care workers and care workers. And actually, they are as vital as anybody working in the NHS. Without them, the system would collapse. And I think actually that hit home with quite a lot of them. And it's something I take every opportunity, and I know the staff here at the County Council do, is to send out frequent messages of appreciation of everything they do. I sent out a personal message to all the staff at Christmas time, because Christmas time you tend to forget, an awful lot of people have to work. And people rely on them heavily. So I think it's a cultural thing, apart from a national thing. The NHS can't operate in isolation. It needs social care. So I think it's something it's incumbent on all of us to actually, when you get the opportunity, say, we do appreciate everything you do. I think it's one of those things, there's no value on that. It's beyond value in a way. So I think that's one of the things that I'm very anxious to do. We have the Dignity in Care Awards each year, and that is so heartwarming. I went to the first one last year and I couldn't believe it, not least the fact that they had a version of Elvis Presley perform. And forgive me for being a little bit flippant, but you could see his white cycling shorts under his white leotard and sitting on the stage. I mean, he was brilliant, but I did have difficulty in keeping my face straight. You can't start tittering away when you're in full view. But the stories there of people who went way beyond their call of duty was heartwarming. And we're looking at actually setting up a similar process to acknowledge the achievements of people in that industry. So those are the things we're doing. It's a cultural thing. It's an everyday thing that we've got to address. I'll hand over to Amy in terms of your question regarding exit interviews.
So just in terms of exit interviews, the first thing for me to do is to acknowledge one of the difficulties we face in terms of bringing that together in a cohesive nature is that within Staffordshire we've got well over 400, nearly 500 individual providers, so they themselves. So one thing that we are setting out as part of the strategy to do is to see, can we bring together that data and intelligence in a more cohesive manner? We are also working with our partners in the NHS. Obviously, they are a single employer, so they can have access to a higher level of data and intelligence in a much more simplistic manner than we can. But what we do know from the engagement and so forth that we have done, in addition to pay and financial pressures, the other big thing for individuals is that appreciation and that thanks. As part of the appreciation and thanks, not just in terms of a pay perspective, what we actually need to do is increase the level of benefits and lifestyle discounts that are on offer to these individuals. So a number of other employees outside of social care will be able to offer those types of discounts and benefits to their employees. So that is something big for us to drive, that the data has told us that we need to focus upon. The other thing that we need to focus upon is employee well-being and being part of a team. So we have more and more providers now talking to us not only about the daily pressures of working within social care, but actually managing the impact that COVID-19 has had upon these individuals. So what we're trying to do is have a direct reach out to those individual employees and make sure that we are promoting those health and wellbeing offers for them. What I would like to present to yourselves within the next 12-month update is that more cohesive overview of what we've been able to collate through those exit interviews on a much larger scale than what we have done to date. If we look at our current statistics, the turnover rate of the workforce is at the moment reported to be 32%. And of those 32%, we do know that we have 59% of people remaining within the sector. So it is a decrease from the year before, so we do want to improve on that. But we want to get much better as a system about retaining people within the sector. So I may not want to work for employee A, but we want to make sure that we don't lose individuals. And the final big thing for retention is training and development, working with those individuals that have expressed a desire to develop through their career pathways, and us making sure that we have a quality local offer that enables them to do just that. We do have statistics and evidence that demonstrates the provision of adequate training significantly impacts on retention rates of staff members. So we want to build on that through considering a social care academy.
Thank you. Phil?
I'm encouraged by the overall answer. I didn't necessarily get I'm encouraged that actually we are looking at it, and I'm encouraged over the last 4 or 5 years there's been a massive different mindset towards care workers. There's no doubt about that. So yeah, I'm encouraged, Mr. Chairman. As the offer Amy said, I'd really like us to look at this again and again to make sure that it is so important. So my question to you would be, let's keep this on the work stream. Thank you. Thank you, Amy. Thank you, Julia.
Thank you. Just let me come back with a follow-up, if I can, please. I mean, my reading of the data is that if people stay after 5 years, then they stay a lifetime in social care. So one of the secrets, presumably, is to keep people for the first 5 years. And you mentioned the difference between social care and the NHS. And one of the things the NHS does really, really well is employee benefits. And I wonder whether you should steal some of those because the schemes are set up and ready to roll. And then you start breaking down the barriers between care benefits and NHS benefits, employee benefits. Just very briefly.
So just in terms of employee benefits, we have extended our county council scheme to the social care sector, so that is VIV Up, and we're looking at building upon those offers further. We are also talking to the NHS, so for example, some of their offers, we are trying to get them free of charge to our workforce.
Thank you, really helpful. Charlotte Atkins.
Thank you. I mean, I very much take Julie Jess's point that the NHS has a higher level of esteem than care workers. But having said that, nurses still had to go on strike to get a decent pay deal. And unfortunately, the whole issue of pay underpins this whole report, which, I'm grateful for because it's a very interesting report. But, when you have a £2,000 gap between the average pay in the social care sector and the average pay nationally, between 19,600 to 21,400, it must make a significant difference, particularly during the cost of living crisis, when a supermarket can offer discounted food to staff, and it's difficult to compete with that. So I do think that one of the issues is very much out of our control, which is decent pay for care workers. There are a number of issues within the report which I'd like to ask about. First of all, it's worrying that the turnover in social work posts is particularly high in those areas in safeguarding roles. I think that's very worrying. And is that related to caseload? Because obviously that's one of the big issues. Another issue I don't think is worrying is the fact that 20% of the children's social care workforce have no social care qualifications. And it seems to me that if we were focusing more on that, and I was interested in the apprenticeships, the social care trainee nursing associates, how much we're using those apprenticeships to try to get people into social care, but also to build the qualifications so that they have some future, hopefully, career progression within the profession rather than just being unqualified. Because I think that is a significant issue. Now, there was one point, we're talking about greater demand from employers for social care specific skills such as personal care now than is available. That particular item in the report referred to had a 10 next to it, note 10. I couldn't find note 10 in the report, so I just wondered what that was all about, the fact that employers are looking for specific skills like personal care, which I would have thought was an integral part of social care. So if you could talk me through some of those issues, I'd be grateful. Thank you.
Who wants to start? Julia.
I'll make a start and then Amy will pick up on some more of the detailed information. In terms of pay, as I say, I don't hide away from that. That would be ridiculous. It is important to people. As I say, I can't disclose today what we propose, but we are proposing as high a figure as we can within our budgets and with the additional funding that central government has given local authorities who provide social care in recognition of those pressures. I think it's always a dilemma, as you will appreciate, Charlotte, as being a former MP. Expenditure can only be paid for by tax. And as it's said in all the media, that we are paying highest levels of tax now that we've paid since the Second World War. Yes, there are extenuating circumstances of COVID and all the support that was given and the support that's been given to Ukraine. But there's always that balance. Any public service or service that's funded out of the public purse, it's down to how much taxation people are prepared to pay. I think there is a strategy now, which is part of the County Council's overall corporate strategy, which is looking at how we can empower people and communities to actually reduce the demand on social care and healthcare, to help and encourage people to retain their independence and you know, be a more sustainable society. And as you know, a lot of work has gone on with supporting communities in that. And we know if we can help people keep engaged with their local communities, they are less likely to require social care. They keep active both physically and mentally. So there is that piece of work going on as a corporate body, as a local authority within the community. And I think this strategy does highlight that if we carry on delivering the services that we do in the way we do at the moment, by 2032, I think we're going to need 35,000 extra staff. Well, I think when you look at the demographics, that's unachievable. So we have to do things differently. Sometimes that can be the use of IT and assistive technology. And we as an authority are introducing that, and we're piloting it with certain care homes to get their interest and appetite for actually, there are certain functions, not all by a long mean, it is a personal service, social care, but there are certain functions that social care staff can do that actually can be done with assistive technology. So we have to keep striving for looking at better ways of providing that service. If we don't, I don't believe personally there's 35,000 additional people within the Staffordshire and neighbouring economies to actually satisfy that workforce need. So I think the report does identify we do need to do things differently. I'll hand over to Amy to respond to Charlotte's other questions. Thank you very much, Amy.
Thank you. I'll just work through and please shout if I miss anything along the way. So we do recognise from a children's social care perspective, we do have a high turnover rate, particularly in safeguarding. I would not be able to give you the specifics today, but I can take it as an action for colleagues that are leading on that specific piece of work to come back to you with a specific update about the things that we're taking. Obviously, there has been a restructure of our children's workforce as part way to address those, but I wouldn't want to give you misinformation, so if I can take that as an action. Moving on to your second point about 20% of the independent social care, children's social care workforce having no social care qualifications, my note of caution would be is that is a very, very small sample. Unfortunately, we do not have in children's the same national data set as we do within adults that allows us to capture that. So that 20% is based on 14 children's social care providers that responded to us during the course of this survey. So I would not advocate that it is wholly representative in terms of the overall skills and qualification of that workforce. One of the key work streams is for us to improve data and intelligence, and there is a specific focus of better understanding our children's social care provision to the same degree that we do understand our adults' social care provision. Moving then on to your inquiry about the hard skills, apologies, as part of the strategy, at the time of publication, the appendices, which gives you the specific reference, was not included. That is taken from a summary of job postings and LinkedIn. So what we do recognise is people already working within the sector have what we call those hard skills. what we are finding is that new people coming to the sector do not have that experience, or they're sometimes not aware of those specific skills that be required, things such as providing personal care. So it is about making sure that people are aware of the expectations of the job and have the appropriate skills training and support to participate within that. So we are seeing it as an increasing issue, particularly as the complexity of our cohort of people that we support, those needs are going up. So that refers to the hard skills, which is something we've got to drive. That relates then into your question around apprenticeships. We are looking to increase the number of apprenticeships across adults and children's social care. And obviously the key component of the apprenticeship for us is that if a provider offers to support an individual to go through that apprenticeship journey, they do subsequently have the employment opportunities at the end. And that is something that we are particularly addressing within adult social care at this moment in time, trying to get the number of providers on board that can run the apprenticeship. So we're working with both NHS colleagues and with the Prince's Trust around driving that local initiative. And we have recently been successful in recruiting, we're going through a recruitment process for 4 apprenticeships within our own in-house services. So we're trying to almost build that local practice of good, that local model, of good practice, building on what we know. So I would hope our apprenticeship statistics will look significantly different over a period of time. And the big myth that we want to bust is that apprenticeships are not just for younger people, they are up for people at all stages of their working lives.
Thank you. And can you come back to Debs or Zach with the information rather than to Charlotte, because I'm sure all of the committee would be interested in seeing the information.
Okay, I mean, just a comment. Obviously, government is about priorities, but, you know, it is interesting that very often occupations or professions dominated by women seem to get a very low priority, whereas the richest 1%, you know, get a huge tax break. I think the priorities are probably somewhat wrong.
Thank you, Charlotte. Let's keep questions brief, please, because we've still got another 4 speakers behind. So, Janice.
Thank you very much, Chair. There's an awful lot of data in there, and you can see, you know, the emphasis on the quantitative side, and my interest was also in the qualitative side. So one of the first things I put down on there was about exit interviews and to get the substance as to the rationale behind certain people's motivations. It's information like that that gives you some ability. I think there's a number of people who remain in care but move around, as well as those that are leaving. So why do they do that? Have we got some of the information as to why one employer is more attractive than another, and should they all be trying to aspire to those? Exit interviews as well. Is it down to some of the systematic processes about, do staff fill in timesheets? Are there delays to getting paid? The impact of zero-hour contracts I saw in there as well. So I think that there's a lot of substance that can be gathered by that data, and there's an awful lot here, and I'm very aware of the size of the task that you're trying to reverse from people leaving to trying to attract thousands more into the process as well. So on that side is also a question as to, and it's taken on a little bit what's been asked previously, what do we do with regards to encouraging work experience to T-levels? I noticed that in the references there's an awful lot of links to universities in there, but again, a bit more information would be helpful as to what those links are and how recruitment is hopefully being encouraged from those. And also things like the National Citizen Scheme as well, to encourage younger people to want to participate and have that exposure to something that they may not have considered previously. A few questions in there. Thank you.
I think Amy has covered exit interviews. They are vital for any employer to understand the reasons why people have left, even if they're going to another provider. I think Amy has said that it's not just us as an employer. Us as an employer, we do exit interviews. But of course there are, I think Amy mentioned a figure of up to 400 different care providers. What we're trying to do with this strategy is to work with them. There are some that will be very proficient in doing exit interviews. There are some that will be relatively small and probably don't do it. And what we're trying to do, and I think this is what's quite unique about this piece of work, is we don't operate in isolation, but what we want to do is encourage good practice across the board, across those providers. And you can imagine that's not an easy task. And as Amy said, in doing that, we can garner that far more valuable information, because that puts the alarm bells up as to, you know, perhaps something you'd not thought of in terms of retention, and retention is valuable. So I'll ask Amy to pick up on the other issues, but it is something we want to do, but I don't underestimate the task because of the variety and scale of providers out there. Thank you.
Just in terms of building on the feedback of exit interviews, the reasons for people moving between providers is largely the same for the as the reasons for people leaving the sector. So they're talking about the differences in pay, learning and development opportunities, and there's also a greater focus on team. So the team ethos and the team support is what the engagement has told us to date. For what we know. In terms of T levels, we do have a focus on, so as you say, the strategy itself looks at does refer to a number of universities and so forth, but as part of the Social Care Academy workstream, we'll be looking to bring into one place all of the different training opportunities at all different levels. So we can support people right from those thinking of coming into social care with no experience to those that actually may want to progress onto their management and leadership roles. So we will be picking that up as part of T levels. We will have targeted and localised recruitment campaigns which will draw on things such as the National Careers Services. So the ICS have recently undertaken a pilot where they've approached 5 schools, and they've gone in at secondary level to talk about working in health and social care and the different experiences that people can participate in. We now want to build on that and take it outside of the 5 schools to get health and particularly social care on people's radar, that it is a career with progression opportunities. And the only thing I would add in addition to that is we are also building a virtual work experience opportunity with ICS colleagues. So once again, people can interact and understand what life can be like working within social care in different roles and with different remits. So a small pilot has been undertaken today, and we're just reviewing the learning and the finding and the impact of that particular scheme.
Yeah, thank you. Not labouring the point on the exit interviews, it wasn't about that. I think we'd already satisfied that part, agree with that. But it was looking at trying to understand the rationale behind 0-hour contracts as well, as an impact of, and also how people physically do get paid. So are some a little bit quicker? Is it the ambiguity of having to fill out timesheets? Is that type of detail there? I just wondered if you got any information on.
We do have some information, but perhaps not the level of data that we would want to. We do not have individuals flagging to us at this moment in time that there are blockages or delays in terms of regular payments being made to staff. What we are very acutely aware of is that if we look at the number of 0-hour contracts, particularly in our home care sector, we know that we need to do a specific piece of work to tackle and improve that, because that will undoubtedly help retention of staff. So that will be a very focused conversation that will be taking place in the upcoming months.
Thank you. Mike Wilcox.
Thank you, Chair. Many organisations will say that they struggle with recruitment, and for some, the introduction of a cash incentive scheme whereby they will reward staff who introduce a family friend or a colleague into the service may well be a way in which to recruit, to get new people. Is that something that we've considered through the work that you've done at the moment?
We can confirm that each individual provider, a number, I would say the majority have attempted things such as cash incentives, be that refer a friend or actually maintaining employment for a period of time. What I would say is that the feedback from providers is what they've trialled to date has had mixed impact. So what we're trying to understand is there something that we should actually say that we know that this level of support works, and try and get some uniformity and so forth, and support providers to implement a positive offer. So it is there. I would say the impact is mixed.
Thank you. Bernard Peters.
Thank you, Chair. Good morning, everyone. Just building on what my colleague was talking about, their personal experiences and those sorts of things, but is it right that a client wouldn't expect to see the same carer every time they had a visit at home? Could it be a different carer that turns up at that property? And I'm framing that question in the context of the digital offer that you're talking about. Because if you have a carer who turns up with an iPad and looks after that client, the next visit, is it possible that you could get a carer who isn't digitally trained, and then suddenly there may be a bit of a gap in information, and maybe the client doesn't particularly feel comfortable with it? Because all about carers and clients are building trust and reliability. So is there a gap there, do you think, that I accept that it's going to be possibly a phased introduction and we're in the early days, but is that something that you see as a particular challenge?
If I can make a couple of comments first. Often with carers, because of the market, people do experience different carers. It can be that one carer is off ill or away on holiday. So there is always that. I mean, you know, we're talking about personal experiences. I know my mother used to complain about different people. And I used to say to her, well, it's actually better to get a different person than no person at all. You know, the problems really start is where there isn't a carer available to turn up. In terms of the digital offer, it's not just about staff and using iPads. You know, it's about having pressure pads so that if somebody gets out of bed, that will alert an organisation that Mrs. So-and-so is moving around. It's blood pressure monitors. It's having dispensing boxes so that an alarm will go if Mr. So-and-so hasn't opened his box to take his morning tablets. There's all sorts of different digital offers. I mean, one of the ones where I'm amazed the impact it's had is an iPad that people can use who are dementia sufferers, that can be loaded up with their personal photographs, their best, you know, their favourite tunes. And it's been piloted, I think, in about 6 care homes. And the individuals themselves can just flick through it. And actually, the results have been quite amazing in the fact that those individuals are calmer, more engaged, potentially leading less medications, less staff input. So there is a whole range. It's not just about computers. I mean, we have rolled out tablets to our learning disability staff. And of course, as an organisation, the County Council, it's far easier for us to roll out and have controls to make sure that staff have the training, there are digital champions and things like that. It is far more difficult within the wider care sector. But I just wanted to flag up that digital is significantly more than just staff having tablets.
The only point I would make in addition to that is we do know that the digital competencies of our workforce is wide-ranging. One of the positive impacts of COVID-19 has been that it's potentially expedited people's digital skills in a quicker period of time than it would have usually. But we do recognise there is still variable competencies. We are awaiting the digital framework which has been developed, which will set out a series of expectations and eventually training requirements for our workforce. So it is being devised nationally. It is in the final stages, and that will set out what we anticipate our minimum competencies will be. And we're also awaiting a response from CQC in terms of how will they support us to implement and to drive forward that particular agenda.
Anything further? Okay. Mike Sutherland.
Thank you, Chair. The items that came from me were around 0 hours, agency impact, and workforce qualification. So I will attempt not to duplicate what's already been asked and questioned. What I haven't got is a feel for how much agency impacts on it. I'm aware from the NHS how the agency can be a big disruptor. But coming back to the workforce qualifications, I think for me, retention is about being, for individuals, there's a feel-good factor, feeling valued, and you can do that variously. I mean, pay is critical and will always be a main driver. However, there are other, what I call softer issues that, if we've got those right to a degree, do work on helping staff retention. And I mean that little regular get-togethers on a local basis. On their birthdays, do we send them a little something? It's just something. Do you know what? It's a god-awful job I've got, but, you know, I do feel good about what I do. So I haven't really got a question there because they've been asked. Thank you, Chair.
But I think what you're touching on is some of those softer benefits, and maybe Amy might want to just expand on some of that.
Firstly, I would completely agree with your sentiments. What the workforce told us is that it isn't always about pay. Yes, they would like, you know, potentially greater pay, but actually is that simplistic saying thank you, celebrating good practice, celebrating where people have achieved a certain qualification, just because, you know, they may not be going through a degree ceremony. It is those very simplistic measures that you have just talked about. So in addition to trying to enhance the level of lifestyle benefits and discounts, the second award ceremony that Julia has referenced, what we are also doing is bringing together we're trying to collate those other ways that we can recognise and reward our workforce, and actually promoting the importance to providers of them saying thank you. So where we get compliments, where we get feedback about an organisation or a specific group, those are the things that we want to start celebrating on a much more routine and visible level.
Thank you for that, Amy. Yeah, you've come back really strong on that. I mean, again, just on the I should have actually mentioned it. On the qualifications, I think if you can get younger people in and give them aspiration, that they can go from level 1, 2 and 3, and we will help support that route. Again, that I always find, or historically elsewhere, that's been quite successful. So thank you.
Julia.
If I can pick up on the 0 hours issue, because I think a number of councillors have mentioned that. Sometimes 0 hours contracts are needed to enable providers to be responsive. You know, it's a competitive market. They've got to be financially viable. And sometimes people working in the care industry, they prefer 0 hours contracts because it doesn't pre-commit them, and it gives them their flexibility that they may want to have to manage their private family commitments. If I can give just as an example, one of the initiatives that we brought in, not this winter, the last winter, was often if somebody who's receiving home care goes into hospital, that care worker's hours were stopped until that person came back out of hospital. We now actually pay that care provider for 7 days. So, you know, if Mrs. Bloggs goes into hospital because she's got a urinary tract infection, comes out in 4 days, that care provider is still being paid. And it's enabled providers to ensure that there is the capacity there. As soon as that person comes back out, their care is still in place. And it's little things like that that we can do. And I think it's a two-pronged approach. It's the wider approach that we're working on with the strategy on the industry, the care industry. But there's also things that we can do, not only as a provider, but also as a commissioner of those services, to recognise where there are weaknesses in the system. And it was the one thing that was, you know, I picked up on, is that continuity of care, even though it be for a week, to enable the NHS to discharge that person quickly and that person's care package to still be in place. So there's a combination of a whole range of things, some totally in our control, some we can be influencers.
Mike, anything else?
No, I thought it was a great response from Julia there, because I just think doing that something a little different just engenders, we don't think about it, loyalty.
Can I just ask a follow-up? Because I think, you know, you've highlighted some of the things that impact on retention. How, when you've got 400 or 500 providers, do you drive, you know, best practice across all of those providers? They can't all do the same thing, obviously, but how do you drive that best practice?
What we're seeking to do across the workforce is there is a wealth of tools and information and resources out there that talk about best practice. Within social care, we heavily promote value-based recruitment. What we want to do as part of this work stream is to ensure that all of our providers understand best practice, and therefore they can then build upon what we would call their own unique selling points to what would attract somebody to come and work for my care organisation as opposed to yours. So we want to create the baseline of best practice, which then just gives providers the springboard for their unique selling points. But we're heavily focused on value-based recruitment.
Thank you. That's useful. Richard Cox.
Thank you, Chairman. I've got just two questions. In terms of the impact of long hours often, if you're covering illness, long-term illness, holidays, etc., and to create a work balance with home life, etc., what can be done to improve that in terms of retention? And then secondly, which does concern me in one respect, because it's quite, only yesterday, somebody said, well, what is social care to me? And that leads me to this question of how can the perception be improved outside of the sector that would then encourage a better understanding of it, and then obviously lead to perhaps more going into that sector? Thank you, Chairman.
Julia, is that one for you to start with in terms of perception and understanding of social care?
Well, I think in many ways I've picked up on a number of those points. It's incumbent on us all. I've stood up in full council and said you cannot expect to recruit people into an industry when you keep slagging it off. You know, that to me is fairly obvious. I say that to NHS colleagues. You wonder why. What you have to do is be honest, but promote the positives. And I think with what we're doing in terms of illustrating to people how they can come into the industry, the virtual reality type of, you know, experience, so that people understand what it's about. The training, the support, the recognition of You know, those who have succeeded in completing a course, which is what we're trying to do with a second event. It all adds to the status and the positive profile of the industry, and that's what we need to do. You know, the Dignity and Care Awards, when you hear the experience of people who've received care from people who have done a phenomenal job, that in itself, you know, generates a huge amount of positivity that spreads well beyond the 200-300 people who attend. It's not an overnight solution, it's something you've got to build on, and that's what we're trying to do. So it becomes, I won't say a professional industry, because that actually could put some people off, but it becomes an industry with a valued profile. And I think, as I say, that's incumbent on us all. So I think it's improving that perception. We've got a long way to go. I don't underestimate that, but I think it's highly achievable.
In response to the query in respect of long hours, we do ask individual providers to consider their offer. So when they are talking to us about that they are experiencing recruitment and retention difficulties, be that for a short or a long-term measure, one of the things that we do ask them to consider is the length of the working day. What I will say is the requests are variable. Some individuals would actually opt for a longer shift type pattern in order to potentially reduce some of the things, you know, the related overheads such as travel and so forth. So we do promote looking at working patterns, and just to say, and it builds into the value in the social care sector, we are stressing the absolute importance of supporting their staff members to maintain physical, emotional and mental well-being, because that is key to retention. So we're doing that through our partners, utilising the resources of the Wellbeing Hub alongside our own Staffordshire County Council offer.
Thank you. I've got another 4 speakers still, so I'm going to draw the list there. But so I'd ask also those speakers to be brief in their questions. Philip Atkins.
Thanks, Chairman. It's such a shame that the County Council has been stripped of many of its responsibilities, because it was the one place that could bring together all the different partners, and then you could come up with a solution. We've heard a lot today about the problems and issues about job retention, the views of workers of social care, the lack of progress, and that all boils down to education, qualifications, because with qualifications, education comes better pay, better service, better understanding of everything else. Nowhere in any of these documents is any mention of further education colleges, universities or partnerships with them. And I speak as a governor at a college and a fellow of the college of, member of the College of Fellows at Keele University. They're having to guess what the future needs are of organisations. And if there's 16,000 and something new care workers going to be required over the next 4 years, that's 4,000 and something new care workers every year, 300 a month, bit over that actually. Put that into something, 10 a day. They need to be able to be enthused, go on a course and do everything else. For the colleges, and they're spending a lot of money on classrooms and everything else so that they can do it, you know, and be prepared. And then they've got to have the trainers to train the people. So there's a lot of work, and the place to do it is the colleges, because they know what they're doing. If you look at the participants' report, they don't like e-learning, they like face-to-face, they want to see that they're going somewhere. If they get a qualification, they can see a way forward, because they can apply for something with a piece of evidence that shows that they're qualified. Not a mention. Can we have that rectified?
Who would like to do that? Julia.
I first refute the fact there's no mention of training and et cetera, within the document.
Chairman, I said further education colleges and universities.
Well,
that's different to training. Training's ad hoc. Qualifications, that are recognised by the relevant bodies is a different subject.
Right. There is a big emphasis on training and that progression and that support. I'll ask Amy to pick up on the academy and the work that's doing on that.
Thank you. Just to provide assurances that our local colleges and universities were involved in the development of the overall strategy. We've listed several of our partners that were involved. If we refer to the work stream that is called Learning and Development, that is where we are looking at picking up a specific social care academy, which will cover, as we've talked about earlier, right from from our entry levels through to degree qualification and so forth. So enabling people at the relevant point of their career, should they so wish to progress through to degree level also. So what I would expect to see, and it will be in advance of the 12-month update, is the establishment of a local social care academy, which I can confirm our local colleges and universities are also feeding in and participating with us on the development of. So I'd be happy to provide an update as that comes into fruition, if that would be useful.
I'll let Philip give the answer, and then maybe we'll talk from a committee perspective. Philip.
Yeah, pleased to hear that. It's the question of who's driving what, because colleges all compete. They are very competitive, and they have to be. And there's some discussion about, I think they've just been changed from being companies to public bodies, so they're now working as public bodies. But yet again, it's another example of more fragmentation. So there's an opportunity for the colleges to be brought together, but it's yet another academy, and people just do not have a clear path. So I'll watch the space carefully.
So just before we sort of move on from this, I mean, is there some value in us looking at a very special, a focus session on education and colleges, particularly in relation to the Social Care Academy, particularly as the backdrop to this is the government is bringing in T-levels as a mandatory career path going forwards from September. So this seems to be particularly relevant and timely, and I tend to be with Philip in his view, which is we need to create it as an attractive career for people. So what do committee feel? Do we feel that we would like to have a more detailed discussion? Because I don't think in a 5-minute discussion here today we're going to get into the sort of the skin of this. And Janice mentioned it earlier. I know Amy mentioned T-levels earlier. What do committee feel? Yep. Bring it back in, bring very specifically the question on education and further education in advance of the Social Care Academy being set up. Because if we do it afterwards, it's a bit late, isn't it? We in favour of that? I think everyone seems to be in favour of that. Is the Cabinet member happy with that? If need be, we can talk about what the specific question is we're looking at. Are you?
Yes, Chairman. I was just conferring with Amy in terms of the best time scales, depending on your agenda, which I know gets very full, probably September, October time.
Providing we can do it in advance of the academy being set up, because otherwise, as I say, it feels a bit more like, we're sort of looking at things in the rearview mirror rather than the road ahead. Philip, thank you for your question. Let's move on. Daniel Maycock.
Thank you, Chair. Couple of comments coming from a personal perspective, because I've worked both in community and in care homes. To me, it's encouraging that the career paths that you're looking at and the qualifications or training that's been put in, because from my experience it was lacking quite a few years ago. Looking a little bit at pay, you mentioned about the 7-day window if a client goes into hospital, that the provider gets 7 days worth of that money. Is that being passed on also to the carer who would have had them hours? And just also, you spoke about the operating in pay. Are we making sure that that's being passed on to the carers as well? Because it's one thing paying the provider, but is the provider paying the carers?
Julia, is this one for you?
In terms of the 7-day continuous pay, my understanding is that is passed on to the individual providing the service. I think in terms of the rate uplift that we pay providers, we can't enforce exactly what they will pay their staff. But staff are fairly acute that if the pay they receive falls below the competitors, that's why they'll move. So, you know, in terms of the annual uplift that we pay the contractors who provide the service, we can't enforce exactly what they pay. But my understanding, the feedback from the first few months pilot that we did of the continuous 7 days pay, that it was very well received and it was paid to the individuals on the ground. Okay.
Cheers, Chair. Thank you. That's really encouraging.
Thank you, Dan. Phil Hewitt, very briefly.
Thank you, Mr. Chair. I'll be brief. It was just coming back to the Cabinet member on 0 hours contracts. Now, I get 0 hours contracts. I also agree with the principle, exactly with the principle of what you said, Julia, on that 0 hours contracts can work for both people. So the principle of that is absolutely spot on. So I want to understand there's no argument with that. What I will say was from my experience of family members who worked, it just doesn't happen. There's absolutely zero negotiation. Now, I think you'll probably give the same answer. It's pretty difficult for us as a county council to do that. But the reality is those are your hours and those are the hours you do. And when you went back and said, actually, I'd rather not work those hours, and I understand, again, it's not a black and white area. You can't say, I don't want to work them because care will still be needed. Absolutely. But from my experience, there was no negotiation at all. If you compared that to sort of a very famous fast food outlet who works 0 hours contracts, there's huge amounts of negotiation, you know, and it's worked through. But nothing at all, zero. Those are the hours you work, and that's the end of that, really. So I'm giving you a question I think it's pretty difficult for you to answer, so I'm more making the point. But I also fully agree with you that 0 hours contracts can be advantage to both people, if there's a level of integrity about them. All right, thank you, Mr. Chair, for allowing me to make that point.
Julia, do you want to just pick up on that?
Well, I think Phil makes a very valid point. You know, there is a place for 0 hours contracts, both from the employer and from the employee. I think how those are used by individual employers, as I say, whilst we may influence, we can't control that. But those employers who do negotiate, have good working conditions, have good relationships with their employees, both in terms of the support, training, pay, etc., will be the ones that will attract the employees. It is a competitive market out there, and employees will go to the employers that actually provide a better overall package. And what we're trying to do is work with employers so that they recognise that we're trying to improve, particularly the benefits package, in terms of, you know, non-pay benefits that people can access. There may well be some employers, some organisations that fail because they refuse to do that. That's the market out there. What we have to do is to work and influence, share good practice, share the tools that they can use, because some of them are not big organisations. They don't have necessarily big HR departments or whatever, but we can help them become better employers.
Thank you. And finally on this subject, Anne Edgeler.
Thank you very much, Chairman. Yes, I'd just like to say thank you for Julie and Amy bringing up about mental health and looking after the carers and their health and, you know, well-being and mental health. That's really good to hear. My question actually relates to the last page of your report where you've got the partners, and I understand reading here about Lichfield working with all the districts and what have you. In what way is that working? How is that, you know, because we've got all these different partners, but I'd like to see, you know, it's interesting not to see all the districts on there. So how is Lichfield working with all the district councils, please? Thank you.
So the page that Councillor Edger is referring to is page 33 of members'
yeah.
packs.
Thank you. It was just that Lichfield was identified as a primary contact point. We, as part of this, have attended and regularly attend the CEO's meeting, which is then subsequently attended by all districts. They have been, for want of a better term, a conduit, so to speak, when we've required a single point of contact. But we have attended the CEO's meeting, which representatives from 8 districts and boroughs do attend to keep them updated, and we've shared the strategy with them. Therefore, we will be moving to a localised perspective as we move to the localised recruitment campaigns and any particular specific issues that we face. So what we may find is that East Staffs need something slightly different to, say, Stafford or Lichfield. So we'll have those localised conversations along the way.
Thank you. Thank you.
Thank you. Thank you, Amy. Thank you, Julia, for your attendance today. Just trying to pull together some of the themes. I think if you look at this committee's 3 big major areas of concern, they sit around primary care access, they sit around system pressures, and they sit around staff. So I think this is a really key piece of work. And actually, I think some of the attractiveness of the way it's laid out and the thought that's gone into it, I think starts to professionalise and provide that voice that I think all members around this chamber would like to see, which helps attract people into the profession and also gives recognition to those people in the profession, because frankly, they do a fantastic job. And we should we should thank those people in social care for the work that they do. And I think the Cabinet member makes a really strong point on that. Clearly, there are challenges. We've referred to a few of those today, whether it's pay or whether it's availability or whether it's driving standards. But I think the assessment is detailed. It seems to cut across 400 or 500 different providers of size, and I think that's really helpful. It's laid out in a sensible way, and the 2 reports, in my view, fit together nicely in terms of what the direction of travel is and why, and you make a good golden thread through that. So thank you for that. That brings me on to follow-up. So we've talked about your offer, and thank you for that, of coming back in 12 months' time to look at progress against the action plan. I think, does that make sense for members around chamber to review progress on this action plan in 12 months? A few more nods would be helpful. Yeah, there you go. Thank you. Just that's the first thing. Second thing is there is referenced in the documents a cost of care, a market sustainability plan being published on the 27th of March. Maybe you could circulate that to us as well, because I'm sure we'd be interested in reading that in detail. There is a date of a workforce celebration event of the 19th of April. Maybe some members would appreciate an invite if there was enough space. I accept if you've got 23,000 people all in one room, all at the same stage, that might not be possible. I mean, I would hope some of them were delivering some of the care, but the principle's there. But if you have some space, I'm sure committee would be interested, because maybe they could be champions in their own communities and in their own councils for the work that goes on through the whole of the industry. And in terms of other follow-ups, I wondered whether the committee would be interested in hosting a round table of some of the care providers themselves to hear their voices and their opinions on the report that's in front of you today. And what I had a thought was maybe we invite Nexus as one of the large providers, maybe we invite 2 or 3 of the smaller providers, someone like Midlands Partnership Foundation Trust as a provider, and maybe the Trade Association, just to get their views firsthand on the report and what's being done and the nuance. Wonder what committee's thoughts are to that as a proposal. A few nods. I mean, it's a key issue for us, and I think if we're... Sorry, Cabinet Member.
In terms of social care providers, I think perhaps Midlands Partnership Foundation Trust would not necessarily be the right organisation. I think the Staffordshire Association of Care Providers would certainly be a good representative body, and perhaps one or two other smaller care providers and Nexus, and that would give you a really good mix of those providing home care and care in home. Okay.
Really good advice, and obviously we will take that, and we will talk with yourselves in terms of making sure we get the right event so that we get the most from that, and that it's reflective of the social care industry. The Cabinet member looks like she's going to say something.
I think it was in response to Councillor Philip Atkins's comments about further education. There was a request to bring an update September, October.
Yeah.
To you. Okay.
Yeah, thank you. Yes, I've got that on the actions. Okay, are we in favour of receiving the report and then the actions we've talked about this morning? Yes. Brilliant, thank you. So can I thank you for your engagement and this morning and actually the work that you're doing to drive the sector so there is a sector voice. I think that's really important. So thank you to the Cabinet member. Thank you, Amy, for that. I think that neatly takes us on to item number 5 of this morning's agenda, which is the Staffordshire and Stoke-on-Trent ICB update, and this is in relation to the strategy. So can I welcome Paul Brown, who's the Chief Financial Officer of the ICB. Can I give you the opportunity just to summarise the papers that we have in front of us? I assume that we've all read them. If you can keep the summary to being 5 or 10 minutes maximum so we have more time to ask questions, I would be grateful, please. Thank you.
Great, thank you, Chairman. Yes, and yeah, thank you very much for having me, actually, because what we're trying to do as an ICB is really strengthen the links, and it's really helpful to have this chance to have this conversation now as we're developing the plan before it's finalised. And there's a strong link, I think, in terms of the plan that to your previous item, Chairman, where you were talking there about the importance of staffing and the issue of staffing and retention of quality staffing within the system. And that's really the key theme for our plan this year, really, is how do we retain the key skills that we need. And the NHS as a whole is really struggling with having enough clinical capacity. So retention, making this a really attractive place to come and build a career is what we're all about. So it links very strongly to your previous item on social care. I think the ICB, as you know, is relatively new, so we've been going now for just about 9 months. So we're still in our infancy, but the concept of the system is obviously a bit longer in the making. And we like to think we're making some good progress now as a system, really working strongly together, and really the whole concept of the plan is the Staffordshire and Stoke-on-Trent pound. How do we use that to the best effect to get the most health and social care for our residents, and increasingly looking across the border between health and social care and trying to break down that sort of artificial barrier that we know exists between the two, and working very, I think, well with your officers in terms of how we do that. I have regular conversations with your CFO. So there are 3, kind of rather confusingly, there are 3 documents we have to produce at about the same sort of time. So one is a strategy, which is clearly long-term, one is a 5-year plan, and then one is a 1-year plan. I'm here really primarily talking to you about the 1-year plan, which is the year that will start in a few weeks' time, but clearly the linkages are there between that and the strategy. I thought just in the few minutes I've got to say a few words about the financial position, because that's my kind of day job, I suppose. Our financial position, I know yours is too, our financial position is really challenged. As a health system, we went from having, probably, I think, decades of significant overspend. In the COVID period, we stabilised that and had break-even finances. And this year that's just about to finish, we are expecting to break even as a system between the ICB and all of our providers, which is a big achievement for us after decades, as I say, of deficit. Looking ahead, it does get more difficult for us. During the COVID period, we had quite a bit of additional funding to support with COVID. That is being reduced and recycled in other areas. So it is going to be a challenging period for us, and so therefore the importance of working closely together to make sure that we get the most out of the money that we have got together. In your pack, I think it's on page 78 of your pack is what we call it a triangle. I see in the PDFing it's gone into a slightly stranger shape. It's supposed to be a triangle, but essentially what that does is from a session that we had with executives from across the whole system, including from your organisation, where we talked about, well, what are the key things that we want to be focusing in on. There's a huge number of things that we have to do, but what are the key things that matter really most to our residents? And we've tried to pick out those and say, well, we're going to focus on those and make sure we make some real tangible difference in those areas. And so those areas are when people are at home and they have to dial 999, they really want an ambulance to turn up, don't they, pretty quick. And when the ambulance goes to hospital, they want to be admitted into hospital quickly so the ambulance isn't on the tarmac outside. Secondly, we've got a huge issue with backlogs for all types of care, surgery care, but also for mental health or autism, etc. So that backlog that's been generated, we want to reduce that and really come down to a much more manageable number of weeks that people wait for their care. The third thing is that people say that they want to be able to get on the phone to their GP and get an appointment pretty quick. So that's a third priority. And then the fourth priority we've called more complex care, because this was recognising that there are a number of patients who have more complex needs. They tend to be very expensive. In many cases, though, patients are being cared for outside of Staffordshire because we haven't got the capacity internally. We want to try and bring that care back into county. That's better for patients clearly and for their relatives, and it's also better for the finances actually, because we can provide that care more cost effectively ourselves. So that's the concept of the triangle. We've identified one metric, and the many metrics of course, but one metric that we're all going to try and come together to make a difference to, and that's category 2 and category 3 ambulance waits. So clearly if the patient has a car crash or whatever, then the ambulance is dispatched immediately. But patients who have, for example, strokes, heart attacks, perhaps they have a fall, those are the patients who at the moment are waiting unacceptably long periods of time after they've dialed for the ambulance before it comes. And we've chosen that one. There's a chart, I think it's on page 79 of your pack, which shows that actually we can all influence that situation. So the patient is on the floor because they didn't have their operation, their hip wasn't repaired, for example, because they had a long-term condition, they hadn't been to see their GP, therefore they weren't on the hypertension drugs, and therefore they had a stroke. Hopefully you can see that the idea is there that we can all get behind that one metric and make a difference to it, so that there are fewer patients who have to dial 999. And therefore, when they do, the ambulances are there to pick up the patient, and when the ambulances do that, they can dispatch the patients quickly at A&E and go back into circulation. So the concept's quite simple. Delivering it obviously is complex and many layered, but really we're looking to work with yourselves and all partners in the system to contribute to that and really make a difference in this 1 year, this 1 year's plan to that particular metric. So at the end of the year, we can actually see that we've made a difference in terms of those 4 priorities that I set out. That's probably about my 5 minutes, Chair. I'm obviously very keen to hear your thoughts and obviously take any questions.
Thank you, Paul. And obviously we're not here to critique the NHS 2023-24 priorities and operational planning guidance, because that is critiqued elsewhere, just in case anyone wanted to stray into that area. I'm looking for an indication as to Charlotte. You're not going to stray into that area, are you?
No, but I would be interested to know when locally we hope to deliver on those objectives, because those national NHS objectives are targeted 23-24. And I just wondered, within this plan, and it sets out some very detailed ambitions in terms of delivery, and this is very much about the approach rather than delivery. So when are we expecting that locally the ICB would be able to deliver those NHS objectives? Now, one of the things it's not, obviously the focus here is avoiding patient harm in the community, which is obviously vital. But there's no mention of integrated care hubs. And given your background is finance, could you just talk us through where we are with the finance for integrated care hubs? Because I thought that the idea of those was to ensure that there was integration between social care and the NHS to do exactly what you're saying here on the informatic about avoiding patient care. And I have to ask as well, one of my obsessions, which is mentioned in the NHS objectives, which is about NHS dentistry. I think most people in this chamber, if they didn't have an NHS dentist already, would struggle very hard to find one. So I'd be interested to know, given it is an NHS objective, how you're going to ensure that we make progress there. Because I understand that the issue around dentistry is actually about the NHS dental contract, and that's why many dentists are choosing to close their practices to NHS patients. Thank you.
And just before Paul starts, in terms of dentistry, I don't know if we've got a date in the summer for a wider review of dentistry, but that is still the plan. So maybe a short response on dentistry, because we'll see it in more detail, please.
I understand, Chair, that the ICB are going to be taking over responsibility for dentistry, which is why I asked the question.
Absolutely, from April.
Okay, thank you, Chair. Thank you for the question. In terms of the when that you've asked first, clearly lots of targets, as you say, and each of the targets will have a when. And what we're trying to do in terms of the plan is, I think it sounds very simple, but make it very clear which partner is delivering against which of those objectives. Because, as you said, your second question about integration, clearly most of the targets depend on lots of people doing different bits to make it happen. And so we're trying to get that clarity as a system so that you can see effectively on a grid, here are the things that we need to do, here's the organisation that is leading it, this is when they're going to do it, and this is how. And we're then going to have that fairly granular ability. If you had a question down the line, well, you said you were going to meet this target, have you or haven't you? We should have that answer and also have the explanation of why we have or haven't and all the detail behind it. Your second question about the integrated care hubs, absolutely fundamental, as you say, to the delivery of this care. Integration of care is absolutely paramount to what we're trying to do here, and completely committed to that. And again, those will be key enablers of the outcomes that we've talked about. So you can think through how an integrated care hub could be one of the mechanisms by which the care is provided to a resident patient. That means that patient doesn't have to dial 999. That's exactly the intention of those integrated care hubs, that they provide that intelligence, that ability to coach the patient, to get the patient ready, to direct the patient into the right care setting. All of that will contribute towards the situation where there are fewer patients ultimately dialing 999 when they didn't have to. And thirdly, NHS dentistry, as you've said, we take on responsibility for that from 1st of April. There is we're inheriting the contracts, and those contracts are underspent in the current period. So in other words, the NHS is not spending as much money on dentistry as it should be, and yet patients can't get NHS dentistry. So you say there's a problem there, and that our responsibility is to make that match up better. But in terms of money, we will actually have enough money to do that. The issue, as you say quite rightly, is around the contract and the incentives to dentists to take on more NHS work. But that's going to be part of our objective to do that and to increase the supply of NHS dentistry.
Can I just say how nice it is to see you face to face rather than a ghostly figure on up there, where it's almost impossible to well, one, to hear you, but also to see what you look like. But what I wanted to know really is when we're likely to have any timelines on this, because strategy is fine, but timelines are also important. So when are we expected to see some of these objectives having a timeline attached to them?
Yes, so sorry, I thought I tried to deal with that, but the plan itself, which we are producing by the end of April, will have timelines against each of the objectives, and we will, in that, have a metric for each of the areas that we will describe what we're aiming to achieve by 31st of March 2024. So you'll be very, very happy to come here and share with you how we're doing against those metrics.
Yes, please. Thank you. Philip Atkins.
Yeah, it's a shame, Paul, you weren't in earlier on, because my question leads on from what we were on about the care. Obviously, you know, there's a lot going on, and I realise you've got to, you're in a difficult position. Well, you were in a difficult position trying to get all the care right and everything else, and you're looking forward. And sometimes you've got to get upstream of what the issues are to stop them coming through the door. And carrying on from what Charlotte said about dentistry, it's funny actually, I was going to ask a question about dentistry. It's obviously a key bit about prevention, because bad teeth mean that you're going to be ill. I'm a member of the College of Fellows at Keele University, and I attended an opening of a vet school on Friday, which was in conjunction with Harper Adams. They're going to have 700 students there in another couple of years' time. And we were talking away, MPs and others, and we were remarking about the lack of dentist schools. There is just one in the West Midlands in Birmingham. So when you talk about we're going to get more dentists, you actually need to start talking to the university, and Keele is our university, and trying to push them into opening up a new dentist school, which could be about 30 million quid, might be 50, but they could use some of the existing university medical school facilities to help train dentists, because they've got some of the first year courses are the same virtually. So, you know, have a word with Trevor McMillan, I think, because we need to start that process off of a dentistry school at Keele University, which will help, and also the lack of GPs. So I'm trying to get upstream and get people trained to help us, rather than, what are we going to do, Chairman?
Sounded more like you're on commission, Philip.
It could be.
I mean, I completely agree with everything you said, and you know, you mentioned Keele. Keele are a really important partner. We want to, one of the hopefully exciting things about the ICB is our role was very much not just about delivery of health, but about the upstream piece, and it's difficult because there's never enough money and all that, but we want to get into that longer term piece, working across, certainly across education, but also across business, and trying to recycle the money within the locality. But yeah, in terms of dentistry, I completely agree. And I've got a friend whose son wants to be a dentist and can't get in because there aren't enough dentistry places, and yet there aren't enough dentists. And it's the same with GPs. It's the same with lots of the medical staffing, and it's indeed true with nursing. We can't recruit enough people, so it's frustrating, isn't it? But you know, we certainly, all we can do in the short term is make this, as I said earlier, a really fantastic place to come and work. And that way we can attract the best people that we can. But we'd certainly support you in lobbying for dentistry at Keele if that was something you wanted to do.
I'll take that message away, Chairman.
Thank you, Philip. Is that the check in the post as well? Daniel Maycock.
Thank you, Chair. Just wanted to dig a little deeper on part of the strange triangle that's been formed. General practice, it says ensuring that residents have appropriate, timely and equitable access to services. I don't know about the rest of the county, but a few of the practices in Tamworth have actually been trying to speak to the ICB and then previously the CCGs about opening more surgeries to cover that backlog of people getting into primary care. But they're saying that they can't communicate with yourselves. Now, to me, it'd be more economical to open a new surgery than having these people who wanted GP appointments, then ringing 999, then having to get backlogged into the system that way. So I'm just asking, can communication be a little bit better with the primary care networks?
So I think what you're asking, Daniel, is have we got the right priority in terms of Cat 2 ambulance calls versus actually should we go further back and be creating more primary care capacity? I think that's what you're asking.
Yeah, to me, in my experience, if you're getting these people before they've got to ring 999 and become category 2, like you were saying about the hypertension meds, recognising faster, then that will reduce that target. So to go a little bit back is going to benefit the target.
On the communication point, I'm surprised and disappointed, but I'll pass you my details. I'm sitting next to you. I'll make sure that somebody talks to your colleagues. But in terms of expanding primary care, I guess our view is that we need more GPs and we need more support staff to GPs if we're trying to increase not just the number of doctors, but the whole clinical workforce. As to having more practices, we're probably less convinced of that. I think a fewer number of well-established critical mass practices tends to be a more effective model. It depends on the locality. You've got to have the GP surgery needs to be accessible to the local population, so it does depend on that. But broadly speaking, we'd be more supportive of where we can actually increase the capacity of existing practices and make them more improve their critical mass, I suppose. But yeah, other than that, I agree with your points. Absolutely, we need that strength in primary care that will, as you say, ensure that the local population only go to that point of dialing 999 because they need it. And we know there's lots of patients who that's not the case for at the moment. They're going into the urgent care system where it's not the right place for them to go, not best for them, because they didn't know or they didn't have access to the right supporting primary care. So, as I say, completely supportive of your proposal. Thank you.
Do you want to come back, Daniel?
Yeah, just a little bit. I mean, to me, and what's been said to me, the practices actually, they can get the staff, but they haven't got a place for the staff to go. So that's why they want to open new surgeries. Thank you.
Thanks. And obviously within the Amanda Pritchard pack, it talks about 20-odd thousand, is that right, extra staff going into primary care. And I would have thought the big issue is the estate in primary care fit for purpose to put in that number of extra people, which I think is what Daniel's hinting at.
Yeah, I mean, if I may come back briefly, yes, but actually a number of patients now choose to have their care by telephone or video, and that's where that's the case, that's good, and that therefore actually means that we don't necessarily need quite as much space per head as we did before, but certainly if there are physical constraints to staffing, we do have a process to look at that. We'll absolutely take that away and look at it, but we're trying to encourage the use of wherever possible digital forms of care, because it's, as I say, it's often what patients want, and it's certainly clearly more cost effective if we don't need to be building new buildings.
I certainly know it's a problem for my local practice, certainly. Tracy, did you want to come in at all online?
I was just about to offer if there was a communication blip somewhere that, again, that you can contact through me. Deb's got all my contact details, as is Zach and yourself, and more than happy to pick that up.
Thank you, that's helpful. Anne Edgeler.
Thank you, Chairman, and thank you for your report, Paul. My question really is, on page, well, it's a comment first of all. On page 75, it's music to my ears, you want to treat mental health the same as physical health, which is absolutely fantastic. And it relates then to page 95 of the report. My question really is, where is the money going to come from to find these extra people to fill the gap in mental health services? Because believe you me, there's so many children out there that are waiting, delayed, because they need the help, but it's not there because we haven't got the people to fill the gap. So my question is, what are you going to do about that, Paul? Thank you.
Given it's a finance question, that's very relevant.
Yes, I can answer that one. So there's a thing called the Mental Health Investment Standard, which was established probably about 5 or 6 years ago. And that was in response to the decades of underinvestment in mental health compared to physical health. So we actually do now, in funding terms, we do actually prioritise mental health over physical care. We put more in. So the difficulty, I think, as you indicated, is actually the staffing side of that. It's actually having the clinical workforce to bring into to recruit, because often those skills don't exist. But yeah, we are prioritising mental health, and as you say, there's a huge backlog. And again, trying to in the plan connect things more strongly together, because often patients who have a mental health condition are struggling to access other services too, and if we can connect those together and look at the patient as a whole, then actually it's clearly much better for them. But again, my day job, the money, that actually works better if you can package the care around the individual. It's actually more cost effective as well.
Thank you. Just we're quite interested moving forward how it progresses. Thank you.
Thank you. Mike Sutherland.
Thank you, Chair, and thank you, Paul. You opened up by saying making good progress. Well, that's encouraging, and thank you for that. And then you went on to, I suppose, the sort of backlog being how do we reduce it, and also GP contact. Those are all outcomes. Now, for me, I'm interested in the plan going forward, and also the time plan of that. What are you expecting short term, medium term, and long term? Because I think it's so big a problem. It's how do you break the pieces down? Because I'd like to coming back in 12 months and then telling us what we probably know because of outcomes from where we are. I would like to have a little bigger understanding of what you're hoping to achieve short term, and then medium term, and of course long term. We could guess, but would like to know that in a bit more detail, because I think the critical thing going forward, and I always, please don't take this as a criticism of CCG. We knew what was not working, but we never knew what was working. And I always thought, it was for the good of the great, but it never actually delivered, and that worried me. And that's my point today, Chair. So I'd like to see, I don't know, even if we came back in September, October, November with a very short, this is what we've planned, this is what's working so far, and this is what's not working.
I don't think we should let Paul and his colleagues off that lightly, that we wait until September, given that he's talking about a plan being ready in April. But Paul.
Yeah, so great question. So you asked about short term. I'll actually start with the long term, because I think the long term is around life expectancy and healthy life expectancy and improving that, and that's obviously many contributors to that, but that's really the focus of the longer term. And the short term, yes, we are going to build those short term targets around the things that you mentioned, the things I mentioned, the 4 things in the plan, and we have got specific targets against them. So if I could quickly go through them in terms of the ambulance weight, I mentioned it's that particular metric around category 2, category 3 weights, and that is a measured thing. So we will count the number of patients coming through that. We actually want to see that number reducing. We want to see fewer patients dialing, because they're actually supported through the integrated care hubs and all the other things we talked about earlier. So there'll be a hard metric around that. There's a hard metric around, once the ambulance does come into A&E, that in 76% of the cases, that patient is seen within 4 hours. That's a metric, and under that, again, hundreds of metrics, but that's the key metric on top. In terms of the waiting times, the target is to reduce down to no patient waiting more than 52 weeks, which is still far too long, but bear in mind in COVID it reached 2 years. So we're looking to reduce that down so that the maximum is 52 weeks. Clearly, there are other standards within that, so particularly around cancer care, and we're actually doing quite well on cancer care in terms of access to cancer care and the immediate assessment of a query cancer within 2 weeks, and then treatment within 2 months, starting from that. And again, those would be hard measures around waiting time. Around GP access, we're measuring the number of, the volume of patients that come into primary care and the speed with which they get their appointment. So I think long-winded answer, but yeah, each of the areas will be a hard metric, and happy to come back at any point and show you how we're doing against those. And finally, Chair, I think a really good point around, we often talk about the things that aren't working, but often don't talk about the things that are working. And that's as important, because there's a huge amount of fantastic health and social care providers, isn't there? And we need to make sure we recognise that as well. Thank you.
Thanks. Mike?
No, I think Paul's answers as best he can. I think it's for us to be comfortable and confident that we're measuring this from our side, as it were, timely. And your point I take on board. I'd like to know, as I say, the short-term plan and how we're progressing against that.
So with committee's permission, we'll liaise with Paul once the plan's there, circulate the plan, and then bring back the KPIs and maybe the first quarter's performance. Maybe that's what we do. But we'll put that certainly into the forward plan if committee are in favour of that. Thank you. Bernard Peters.
Thank you. Good morning, Paul. In the context of the way you've described the ICB, the coming together of all parties, I wonder if I could just sidestep that a bit, because I've been reading recently the amount of people with type 2 diabetes in the UK is, or living with diabetes and not knowing it, in the category of type 2. Now, a lot of those people end up with significant health problems because of the poor intervention. So are you reaching out to, I know it's public health and social prescribing, which is the pathway for trying to deal with obesity and type 2 diabetes, but don't you think there's a bigger part for you to play to help people understand that if they are obese, you're going to be picking up a lot of cardiac and respiratory problems further down the line? I always think there's a gap there in terms of the joined-up approach to it. Any thoughts?
I mean, you're spot on. Diabetes is a really, really significant condition because of the points that you make. I think up to sort of 10% of the work that the NHS does is for patients with diabetes of one sort or another. And yeah, the point you make about, again, the upstream piece of that and helping people with weight issues to deal with that, so that they don't develop diabetes in the first place. That's exactly right. I mean, our challenge, as always, you face it too, is that balancing that long and the short term. And ideally there'd be lots of money to invest in the longer term, and we're trying to make that balance. And at the moment, it is difficult. It is difficult, but we're absolutely focused on ensuring that we don't get purely into the short term. We do make some of our investments into that longer term position, so that we do make a difference downstream, and often it can be sort of 10, 20 years downstream, can't it? So I could only agree with you, but say, unfortunately, it's a very, very challenging thing to do, to balance off those longer and shorter term things. But we've got within, I should have mentioned it earlier, we've got 7 portfolios. I don't know if that's been mentioned to you before. We've got 7 portfolios that we're working on, which are effectively the care pathway. And this is an attempt to try and bring different providers in to work together, rather than working down working with UH&M and MPFT, and combine working with providers across the piece. And one of those is around long-term conditions, which obviously is diabetes is one, and that portfolio is really looking at exactly what you're describing. How can we make a difference to that longer-term impact on that patient cohort?
Bernard?
Yes, there was something on the radio this morning, and a very controversial phrase was used. If we don't get a grip, it could well bankrupt the NHS, treating the legacy issues of diabetes. And that's on top, a really aggravating feature on top of the financial circumstances you shared with us at the beginning. So I don't get a sense of, I know this, I don't mean this the way it's, I don't get a sense of pace from the NHS in terms of trying to get a grip of this. I really, really don't. There's a lot of reading on it, but wherever you go, you find there are various obstacles in the way to social prescribing or people being educated and informed of the consequences of being obese, type 2 diabetic. Take control of your condition, and my words, no one else's, or else. That's the powerful message that needs to get out there. Thank you.
Paul, do you want to come back on that?
Yeah, a little bit, because I know what you mean about the sort of sense of lack of pace, but actually, I think there are things happening in lots of different parts, and one statistic that is not a good statistic for the NHS since COVID is that we've become less productive. So we've actually increased our workforce by about 20%. This is national. This isn't about our patch, by about 20%, and yet patient activity is actually down. You might be surprised to hear. You wouldn't think it would be looking at the A&E department, but there's 10% fewer patients coming through the entire NHS. So therefore, simple maths, the productivity is down. Now, unlocking that productivity is extremely difficult, but we have invested in additional roles into primary care. So we've got they call health navigators, they help patients at source. We are investing in social prescribing, you mentioned. We've done a lot of investment. What we haven't yet been able to do is really capitalise on that. So, I'm probably slipping now into my CFO role. That's how I see the world. I think we can do more with what we've got. And of course, I'd like an awful lot more money, but we need to do more with what we've got. And I think there's a lot more that we can do. I'm not saying we can solve every single ill. Of course we can't, but we can do better.
Thank you. I'm just going to ask a question and then bring in Daniel in a minute. So on page 77, you talk about the janitor and the JFK effect. And I'm not convinced I understand what either, well, I understand both. I'm not sure I understand what either of those are. So maybe you could just give a summary for those of us who don't understand the janitor and the JFK effect. And the second question I wanted to ask was, right at the outset of your presentation, Paul, and thank you for that, you talked about the financial break-even, which I think should be celebrated, bearing in mind the journey that we've been on. Can you just give us an indication as what the impact of the break-even is? Because whilst I understand the pounds, shillings and pence, I don't understand the financial impact. Thank you.
Great. Yeah, thanks for those questions. Yeah, so I never quite know if this is a myth or not, the janitor story about JFK, but there's certainly a story that does the rounds, which is that JFK was in NASA one day and came across the janitor and said to the janitor, what do you do then? And he said, I put men on the moon. And that's the concept, really, we're trying to get across, is that actually, if we ever get to the point where you could go to any member of staff, we employ 30,000 people, any one of them, and say, what do you do? Well, we avoid patient harm in the community. We ensure that when the patients don't have to require ambulance care. That's the concept, is really to try and create that common bond. In terms of the second question on, I've written the word impact. Sorry, what was the question? Come to me in 2 seconds.
2 years of break-even.
Yes, impact of break-even.
What does that mean?
My shorthand didn't work that time. Yeah, so a specific outcome is that we've been given additional capital as a reward. So we've been given 6 million extra capital. The second thing is that as a system, we have a legacy financial debt, which is 300 million, big number, 300 million that's accumulated over the decades. And if we can secure a break-even 2 years on the trot, that 300 million gets written off, which is obviously a lot of cash for our locality. Those are probably the two direct things I can think. Indirectly, we are now seen as a system that is on top of it, and I talk to my colleagues where that's not the case, and they spend their life forever chasing their tail. We're allowed to get on with things and make investments. There's a concept called the triple lock, which is for those systems that are in deficit. They basically can't spend any money without getting approval. from the centre, which slows everything down. So whilst we're in break even, we're allowed to make the investments where we think they're the right things to do.
Thank you. A really important point, given I think for much of the last decade we've probably been in that chasing our tail position. So it's a big achievement, and well done on that, Daniel.
Thank you, Chair. Just skirting around the NHS priorities, but it also locks in with the councillor's question over there about diabetes. Saying that you're going to reduce, where is it, sorry. Increase the percentage of patients aged between 25 and 84 years with CVD risk score greater than 20% on lipid-lowering therapies. Now, again, it sort of goes back to my question about estates. That can't be done digitally. It needs to be done, blood pressure, weighing, set of bloods. So how are we going to get people through the door if the door's already blocked?
Yes, and absolutely. I'm certainly not suggesting that we can do without good quality physical estate. In fact, that is definitely part of our plans, is to have more high quality physical estate. As you'll probably appreciate, we've got lots of estate which is not good quality. So it's a combination of those things. We across primary care, we actually do have overall underutilised space. You might be surprised. It's more in Stoke than Tamworth, I have to admit. But across the piece, we do have unutilised estate. So we're trying to look at options for putting back office functions away from that estate where we need it. But no, again, point taken. And you know, not everything can be solved with existing estate. In some cases, we do need to purchase new land and build new buildings, and that's very much part of our plan to do that. But capital is limited, so we're trying to minimise that unless it's absolutely essential.
Anything else, Daniel? Okay, thank you. And so, just as a final question, let me pick up a couple of areas. Your man on the moon discussion, I think, is really relevant to the key objective or key metric, which you outline of Category 2 ambulance calls. I'm not sure if I worked in the NHS whether that would be sufficiently motivational. And I was really quite surprised. I read the strategy alongside the delivery plan, and I really struggled to say, how does this lot fit with that lot and integrate between the two? And certainly it feels like a very operational key metric. And I really struggled with it. I thought, who's picked that and why? And where is the link with all the other elements on page 77? So that's my first question, which is about, is it a visionary objective that people will get behind? Second one was, I'm not sure I saw enough from population health management to demonstrate the identification of where the need was and then the focus to it. So could this be a document that I see in Shropshire, I see in Kent, I see anywhere else around the country? And I couldn't work that one out either. Somebody touched earlier on upstream, Philip Atkins, I think, and I also wondered whether there was enough focus outside of the NHS. And Philip often talks about NHS and buildings, and we always focus on buildings rather than on all the other things that come within the system. And I just wondered whether there was enough on upstream prevention and that linkage. And to pick up Bernard's point about individuals' responsibility. I didn't see anything, and I talked about this last time. There needs to be a clear charter between the individual. You can't abuse your body for 100 years and then expect the NHS to fix it in the last 10. You know, it just doesn't work that way. And there needs to be, you know, a very clear, you know, this is what I'll do if that's what you will do. And just wait for it. And so there is that link there. And as I say, I didn't see where the link was back to the strategy. Just let me bring in Philip, because I think he'll add to the question, or maybe he'll derail it. Let's see.
Yeah, no, I'll add to the question. I think sometimes they used to say you need to lift the blinkers. And I'm referring specifically to the dentistry school. So while I've been sitting here, I've been messaging the Vice-Chancellor. It has been looked at. And, you know, because they're looking for easy win courses that don't cost a lot of money. So, you know, I've said, well, I've got a minute. So they're going to revisit it. And Trevor is the Vice-Chairman of the Shropshire and Telford and Wrekin ICB. So it's not only Staffordshire have got a problem with the lack of dentistry and all these other things, the other areas have as well. And the strength of two is better than one.
So, Paul, maybe focus on mine, because I think we've already answered Philip's.
Yeah, and yours are all good, and I find myself agreeing with most of them, to be honest with you. But I think it's kind of all this is work in progress, really. So is it visionary enough? Does it tie to the strategy? Yes, it does. It does tie to the strategy. We work very closely with the team pulling together the strategy. But is it visionary enough? Well, that's probably a fair accusation. I suppose what we've tried to do in this year is focus it around more of a managerial approach, which is how do we get all the leaders of all the different parts of our system together to work together to deliver, you know, tangible improvement, real improvement, which probably is not quite it isn't at all really the JFK thing. So you're right. There's work to do in terms of winning the hearts and minds of our cleaner in MPFT or our junior doctor in the A&E department. But it's a start, I would be my response. You know, the start is pulling people together to come behind a metric. We've never had a single metric across the system before. So if we can deliver on that, then it's a good start. I think population health management, which was your second point, is absolutely right. We haven't yet done enough around really understanding the differences of our different populations and actually targeting money and resource and capacity, flexing that resource to reflect that individual demographic. There is more to do on that, and we are doing a lot of work around population health management. I think you'll see a lot more in the next year's plan. By then we'll have had a year, hopefully, of really getting that drill down into the data, and we'll be able to reflect those nuances much more strongly. At the moment, it's work in progress, and so therefore I think it's probably again a fair charge to say this is a bit vanilla flavoured across the piece. Enough focus upstream. I think I think there is more focus upstream than perhaps the document shows, and so hopefully when you do see the final product, you'll see a bit more of the upstream stuff. So the sorts of questions around, well, what are you doing around diabetes, long-term conditions, they do feature in the plan, and you'll see the specific actions. So I think there is more there, but again, it's hideously difficult to deliver long-term benefit when you're trying to get a short-term plan together. But that's always the way, isn't it? So I think there's a bit of truth in that charge, but I think there is perhaps a bit more there than so far shown you. And responsibility of the individual, completely agree with that as well. I guess this is, again, it's a managerial plan. It's what we're going to do together to deliver the improvements. But you're quite right, and Tracy's on screen, and getting messages across to the public around what they need to do, the responsibility they need to take. I agree with that. But perhaps doesn't quite belong so strongly in an operating plan, I would argue. But again, I take the feedback. It's helpful.
Okay, thanks, Paul. Tracy, do you want to come in, or are you happy?
There will be public versions of the different documents anyway. I think it is quite, I think you used the words, didn't you, operational, and I think that's probably what it is in terms of the plan. The conversation we need to have with the public obviously needs to speak to the public in language that they will understand and get motivated with.
Thanks, that's a good point, and I had not recognised that there was going to be a separate plan that goes with the plan. Okay, thank you. Does anyone else have any... Janice?
Thank you, Chair. I think when some time back when the Women's Health Strategy was published, this group started a task group, this committee rather. And I noticed that there's a bullet point somewhere in the appendices on this about having due regard to the women's health strategy. And it may well be that we're being a bit efficient, hopefully, but we're looking at having contacts, and I know I've spoken previously with Tracy about having contacts within the ICB. Is there any progress on that yet? Because we're still awaiting some feedback from those. So the work that has been started with the task group can be pursued more collaboratively, if there's an answer for that. Thank you.
Tracy, is that with you?
Yes, it is, and I have raised it with Paul Edmondson-Jones, who's our Chief Medical Officer and also leading on the population health management. And I thought we had a name for you from our side, Councillor, but I think it's also looking at the wider system and where do we get people from in terms of provider services, because women's health is a huge issue and across all the different providers. So leave it with me, but I know Paul had been putting people forward around who should come from an ICB. So I'll just, if you leave that with me, I'll certainly chase that today.
Thanks, Tracy. I think that brings us to a close on this item. So we're asked to note the report, and there were a number of actions that came from that. I think it was a useful discussion, because I think what it's thrown out is that this is very much work in progress. And I think the point Paul didn't make, but was close to, was actually this isn't new stuff, because the NHS isn't created from every bit of new strategy because there's a new ICB. So effectively, there are already strands of activity that have been rolling, and it's about pulling those together and focusing on them. I think the actions that we talked about were to bring back the KPIs, a timeline and a plan that will be created in April, and then to just go through the first quarter's performance. And obviously to share the details on women's health contact within the ICB. Is that in line with everyone's thinking? Are we all happy with that? Good. On that basis, Paul, thank you for your input this morning, and we look forward to seeing you again, both with the plan, which as soon as you've got it in April, it'd be good to see, but probably, I guess it'll be a September one, won't it? Okay, thank you for that. You're welcome to stay. You're welcome to go. We're going to move on to the next item of our agenda, which is district and borough scrutiny meetings. So before we kick off on that item, I would ask you to ask your officers to only send health-relevant information, please. Otherwise, we all waste a lot of paper and time reading stuff, which is interesting, but not hugely relevant. And if people are interested in it, may I suggest that they visit the district and boroughs' websites and pick up their minutes, rather than needing to read about lots of things that aren't necessarily relevant to this committee. Phil Hewitt.
Thank you, Mr. Chairman. Can I just say that I've been on this committee 6 years. I must have been a very bad person in a different life. And I always ask to come on this committee. It's an excellent committee. It's a committee that scrutinises well, and I'm quite proud to be on this committee. When I came 6 years ago, we did this, and we did the process of a report from the boroughs and districts, and it quite saddened me that there wasn't a lot of reports, and so I read some of the Francis report, which is an interesting bedtime report. It's an interesting bedtime read. And that talked about working with districts and boroughs and how important that was, and how the Francis report. And it always concerned me, and I brought up time and time again, that actually if we didn't work with districts and boroughs and things went wrong, then the reality is Francis or his equal would come back to us and say, well, this is what I asked you to do and this is what you didn't do. So can I congratulate yourself and the officers that we are now getting fairly comprehensive reports. I accept what you're saying, Mr. Chairman, that we probably get too much, but I'm going to challenge you on that I would much rather have too much than what we was getting, which was nothing at all and poor or little or no representation. And I'm going to take a little bit of that. I have mentioned this many times to you and previous chairman, haven't I, that this is really important. And certainly there's a very comprehensive report from Cannock, so I'm pleased about that because that's where I live. But can I just congratulate that we are getting quite good reports, and we're getting regular reports in writing and attendees. So I think we're getting very close to complying with the Francis report. So it's merely congratulations to you. And we can get it better, I agree with you, but it's worth noting the improvement, Mr. Chair.
I'm happy to note that. Can I just sort of follow up that point? Because I think you make a good point in as much... In as much as when we roll into the next municipal year, I do think it would be worthwhile getting together as a small working group just to look at some of the actual detail things happening across the piece, because I'm sure that the district leads will be looking at their work programme for the next 12 months at the beginning of the municipal year, and you may want to steal and beg and borrow from other people and just look at some things that are relevant, accepting that we will have different flavours to our areas.
Can I come back?
Yeah.
I think in some ways it was never explained. It was never explained why the district and boroughs were here. It was never discussed, so certainly nobody discussed it. We may have to go and research it for myself. So I think if we had a working party with district and borough representatives, even included officers, to fully understand why this takes place, I think it can improve again. So I think I'm in agreement with you, Mr. Chairman, and that's twice in one day. So excellent. Thank you, Mr. Chairman.
I better go and get a national lottery ticket, hadn't I? And obviously the bit I didn't say was I think the Staffordshire Leaders Board has or is signing off new terms of reference. Has.
Yes, Chair, and the Staffordshire Leaders Board have approved the joint code of working for health at district and borough councils. Now the leaders are taking that report back to their own councils to consider how that will work within their own organisations, and there has been a request for the constitutions to be amended to reflect that the joint code will be a place of reference for district and borough councils and scrutiny.
Thank you. And would it be wise to circulate the paper that went to the Leaders Board? Is that within our remit to be able to do that?
Thank you. Yes, Chair, it would be.
Thank you. Okay, well, maybe we'll circulate that this week, and then when we get back in the new municipal year, we can pick that up. Okay, we can get a date in the diary, can't we? That would be a sensible thing to do. So, okay. Brilliant. So, we've got in front of us a report from a variety of different districts and boroughs. I don't intend to go through that in detail unless that is any of the districts or boroughs want to pick that up. Mike, I will come to you last, please, because I'm sure you've got some other stuff that you want to talk about. So does anyone else? Pip.
I just wanted to add that myself and the committee members from Cannock Chase District Council attended Royal Wolverhampton Trust Hospital and had a tour of their virtual wards. If any of you would like those contact details, I'd be happy to set it up for you because it explained it completely, made it sort of aware what a virtual ward was, not just an iPad. They are out in the community and the fantastic work that they are doing, delivering and rolling out further and using as a model. So if anyone's interested, let me know.
Is there any interest? I missed out on that, so I'd be interested in going because I meant to go and managed. Yeah, okay, so it feels like that maybe we will, as committee, put a date in the diary for, we'll go as a committee and we'll aim for doing that some stage in May. Yeah. Okay, good. Thank you for that. Very helpful. And in terms of virtual wards, I think there are 75 virtual beds at the moment within Staffordshire with an aim for, I think the number is 750.
I'm not sure of the numbers. All I know that is there's going to be 10 in Cannock Chase District.
Brilliant. Thank you. Okay, so is there anyone else who wants to? Daniel.
Yeah, just a bit on the Healthier Communities paper that was sent out a couple of weeks ago, or was it about a month or two ago? Just that Tamworth's in the process of making 3 strategies on the back of that report, and we've got a single item evening in April, which isn't put on that report, where we'll go through all the recommendations that have been in this committee's report and see how we can implement them into Tamworth.
Thank you. And anyone who's read these reports will see there's a theme through some of this, which is one of the themes is disabled adaptions. And I suggest at some stage we might want to have a look at that. But I think we just, given there's a change of provision within the county, leave that to rumble for a while so that districts and boroughs have time to set those systems up. Does anyone else have anything they want to add? So I'm going to come to Mike. I know you've not asked to speak.
Thank you, Chairman. Yes, we did, in fact, at our meeting last week, invite the ICB to come and talk to us on two issues that affecting our residents, one being the George Bryan Centre, and the second being the Burntwood Health and Wellbeing Centre and the imminent closure of the practice there. We had, as I say, we had a good explanation from the ICB. We gave it a good thorough examination and scrutinised it. We were expecting a few more members of the public to turn up. That didn't happen, but never mind, they're very vocal otherwise. And there's ongoing work from that. There is a potential protest being planned for this weekend at the Health and Wellbeing Centre. But certainly members were able to cross-examine, as we'd say, the ICB and their plans and the rationale behind the decisions they're taking, and we certainly had a better understanding of what's happening. So we just need to make sure that that is out there in the public so that the public understand what is happening. But that will get reported, and we'll send in a report to come in with this report at the next meeting, Chair.
Thank you, appreciate that. Okay, does that move us on to the next item on our agenda? Are we happy to move on? Yep. Okay.
Chairman, I was going to comment on the grazing animals in St James's Church in Audley to keep it tidy.
So item 7 is the work programme. Just in terms of the work programme, can I make a couple of suggestions? We've talked today about creating an action log to go with the future minutes. I think we need to probably do a bit more work on the work programme to put the dates round, future meeting dates round the current plan. I think we probably do need to flesh out some of the actual next 12 months worth of items. And there's a few things we need to pick back up on, for example, maternity. So I propose that between myself, the vice chairs and the officers, we look at that in the next fortnight and then recirculate to committee so that there is a draft plan. I don't think we should agree the plan at this moment in time apart from for the first meeting. And then new committee can decide what their agenda and what their priorities are. Are we happy with that as a proposal? Thank you. And on that basis, I think that draws the meeting to a close. Thank you for your attention. Thank you for coming. And thank you for the input and insight you brought this morning.